Welcome to our educational video on knee joint thermal radiofrequency ablation using Coolief cooled radiofrequency technology. Thermal radiofrequency ablation of the knee joint is indicated for patients with chronic knee pain greater than 6 months and not adequately managed by conservative therapy. In our video today, we'll describe a very simple technique that will allow for the procedure to be done safely with minimal discomfort to the patient. Proper positioning is most important with this technique. If you abide by a few simple rules for positioning, you'll find that the technique is very simple and safe. Here in our initial scout view, you can see that the patella is adequately centered and we've optimized visualization of both the medial and lateral compartments. In order to appropriately perform a knee joint radiofrequency ablation procedure, we need to identify the genicular nerves. Fortunately, the genicular nerves are at very reliable anatomical landmarks as we visualize the knee. They're located at the juncture of the epiphysis and diaphysis at each of the 3 targets. The 4th genicular nerve, or the infralateral genicular nerve, we will not be lesioning. Its proximity is much too close to the common peroneal nerve and cannot be reliably and safely ablated. As we turn our attention to this fluoroscopic image, we can see where the epiphysis and diaphysis juncture is at all 3 sites. This nerve is located several inches superior to the superior aspect of the patella. In our scout image, we can see that the patella is midline and we have appropriately crisped off both the medial and lateral compartments. What we want to do is identify the anatomical location of the genicular nerves. Once we have the patient properly positioned, we can then obtain our initial scout view. This scout AP view is optimal. It centers the patella and crisps off both the medial and lateral compartments of the knee. Here we can also identify the juncture of the epiphysis and diaphysis for all 3 of our genicular targets. The 4th branch that we'll discuss later is in the suprapatellar region. When we start the procedure, we have to make sure to not anesthetize too deeply. The genicular nerves are very superficial. It is only recommended to anesthetize the skin surface to facilitate appropriate, safe, and less painful introducer placement. Once appropriate local anesthesia has been obtained, we'll take the introducer tip and lay it over the skin to overlie the target lesion site. The introducer here will be placed over the juncture of the epiphysis and diaphysis for the supralateral genicular branch. Using a down-the-beam approach, we'll introduce our 17-gauge introducer through skin, and we'll take a scout image. The introducer can then be safely manipulated towards periosteum using a slightly medial trajectory. Be careful not to introduce too deeply. The maximum depth is 50% across the distance of the bone in question, either the femur or the tibia. Once you're able to receive appropriate tactile feedback that you have touched periosteum, stop. Make sure that you place all 3 introducers, and then we'll move to lateral films in order to verify appropriate placement. In this image, we can see that the introducer is now touching down on periosteum. I will now begin to introduce the other needles to approximate the genicular branches that we will lesion. After concluding placement of the initial approach to the supralateral genicular nerve, now we'll move towards the supraomedial genicular nerve. I'll place my introducer tip over the area where that lesion will take place, and I'll gently introduce it into previously anesthetized skin. I'll slowly manipulate that needle along the periosteum until I have tactile confirmation that I'm touching periosteum. Here, I feel the tactile feedback of the periosteum. In this image, you can see optimal placement of the introducers in order to access the supraomedial genicular nerve and the supralateral genicular nerve. Now we'll move to the infraomedial genicular nerve. Once again, the infraremedial genicular nerve runs at the juncture of the epiphysis and diaphysis. Don't be concerned about the genicular vessels as they run very close to the joint lucency. After obtaining appropriate skin anesthesia, what we will do is place our needle tip at that juncture of the epiphysis and diaphysis, and we'll enter skin. This nerve is the most superficial of the three genicular branches that we will be ablating. It is not uncommon in patients with low body mass indices for an eschar to form because this nerve is so superficial and we have a large volume lesion that we are creating. For the infraomedial branch, we'd always like to leave it short at first. Sometimes it's not even necessary to touch the periosteum prior to manipulating on a lateral view. This is typically the case in patients with low body mass indices. For the infraomedial branch, it is always best to keep the needle distance short relative to the skin insertion site. It is not uncommon to drive the needle too deep on first approach. Now that the introducers have been placed to access all three genicular nerves, we'll move to lateral imaging. Since we already have the leg bolstered, we don't have to worry about the down leg interfering with our lateral view. Here on the lateral view, we can now see that the depth of the introducer is approximately 50% across the distance of the respective long bone. Now we'll place the probe and secure it into place with the Luer lock. In this image, I've placed the probe through one of the introducers. You can see how the radio-opaque band is now 50% of the way across the distance of the tibia. At this point, we would perform motor stimulation at 2 Hz to 2 volts and note any twitch response. Once we are able to verify a lack of a twitch response, we'll inject our local anesthetic through the side port and we will begin radiofrequency lesioning at 60 degrees centigrade for 2 minutes and 30 seconds. At the conclusion of lesioning, the apparatus can be removed as one piece or additional local anesthetic can be injected. Once the probe has been placed and motor stimulation has been trialed at 2 Hz to 2 volts, then we need to move back to an AP view in order to verify that we have not strayed from our proximity to the long bone. In this image, I've placed probes for the infraremedial genicular branch as well as the supralateral genicular branch. You can see that the radio-opaque marker is approximately 50% across the width of the long bone. This is optimal lesion positioning. A second lesion can be placed by slightly pulling back on the probe to a distance equal where now the needle tip lies where the radio-opaque band was for the initial lesion. Remember, if you are going to do a second lesion at a target, you must motor stimulate at both sites prior to ever injecting any local anesthesia. The fourth and final lesion in our protocol is the suprapatellar branch nerve. This nerve is easily located in the midline above the patella. It runs a course from superior to inferior towards the middle aspect of the patella. Using our introducer, we can measure out an approximately 50 millimeter distance from the superior aspect of the patella. By staying in the midline, we can introduce at that juncture one time through the skin, and we will immediately touch down on periosteum. This image shows appropriate placement of the introducer for the suprapatellar branch nerve. Once I remove the stylet, it will allow the introducer to be superficially suspended off of the bony periosteum. The probe is then placed into the introducer and secured with the lure lock, and we then make sure that it has maintained its positioning in the midline. Now we're ready to move to lateral viewing in order to verify placement. Here, on our lateral view of the suprapatellar branch, we can see that despite touching periosteum during our AP approach, the needle tip lies superficially suspended off of the periosteum. This is exactly what we would like to see. Once the probe is secured via the lure lock into the introducer, we can now see optimal positioning for the suprapatellar branch. Introducer position here, as seen on lateral view, allows us ample opportunity to access the suprapatellar nerve, which lies superficially suspended in tissue above the femur. After the lack of a motor twitch response has been confirmed, we can then gently instill local anesthetic through the side port prior to beginning radiofrequency lesioning at 60 degrees centigrade for 2 minutes and 30 seconds. During the normal 30-second ramp-up time, I like to move back to our Scout AP image to make sure that no introducer migration has occurred. After verifying appropriate placement on lateral, it is now prudent to come back to an AP image. The AP image will help us to decide whether or not any introducer migration has occurred from any manipulation during lateral view. Radiofrequency lesioning, per protocol, is carried out at 60 degrees centigrade for 2 minutes and 30 seconds at each site. Here, you can see the superolateral genicular nerve is being ablated simultaneously with the infraremedial genicular nerve. At the conclusion of lesioning, additional local anesthetic may be injected prior to removing the apparatus as one piece. Note during our confirmatory AP images with probes in place that the introducers lie just adjacent to the periosteum. Thank you for watching our educational video utilizing Coolief cooled radiofrequency technology. We hope that you find this technique useful in the treatment of chronic knee pain.